Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to What We Know About Omicron in Children, an international webinar conducted by the International Pediatric Association. Uniting over 3,500 registrants from all over the world, the What We Know About Omicron in Children International Webinar discusses the highly transmissible Omicron coronavirus variant that has swept the globe in the past few months, impacting a large number of children with several cases severe. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the President of the International Pediatric Association, followed by our honorable keynote speaker. Then we will have the presentations from our distinguished panel of experts, moderated by our esteemed moderators. Today's webinar will then be concluded with a question and answer session. To officially open the What We Know About Omicron in Children webinar, we will now respectfully invite our first speaker to deliver the opening remarks. Professor Enver Hasanoglu, MD, FAAP, is the president of the International Pediatric Association, Secretary General of the Turkish National Pediatric Society, and Secretary General of the Union of Middle Eastern and Mediterranean Pediatric Societies. He has also held the rectorship position in Gazi University, Ankara, Turkey between the years 1992 to 2000. He was the dean of the medical school for 9 years and a member of Turkish Higher Education Council for 4 years. For the past 20 years, he has been involved in many programs in Turkey and in the Middle East region, especially on immigrant child health matters. He has been awarded many honorary fellowship titles by various societies across the world for his tireless work and contributions to child health. Without further ado, to the professor who needs no introduction, to Professor Hasanoglu, the time and screen is yours.
Dear colleagues and friends, I would like to welcome all of you to our meeting, and I am happy to be with you, and I am happy that there is more than 3,500 participants in this meeting. As you know, we are suffering and dealing with this problem, which affected our life negatively. I am speaking about COVID-19, and more than 1 billion of our children has been affected from this pandemic. Now, we're facing with a new variation of COVID-19, which called Omicron, and it is milder in children, but it has so many complications. We are going to listen to our expert speakers from the world, all over the world, and we should consider about this which became so urgent problem in our life. And this webinar are going to learn about these problems from expert speakers in details. I would like to express my sincerest thanks to our speakers, to our moderators, and of course to you who participated to this meeting. Thank you so much.
Thank you, Professor Hasanoglu, for your opening remarks. We will now proceed to the next agenda of the webinar. Today, we are very honored to have the next speaker deliver the keynote speech for today's webinar, Mr. Budi Gunadi Sadikin, the Minister of Health of the Republic of Indonesia. Without further ado, we respectfully invite Mr. Budi Gunadi Sadikin to give the keynote speech. To Mr. Budi Gunadi Sadikin, the time and screen is yours.
President of the International Pediatricians Association, Executive Director of International Pediatricians Associations, and the participants of the Pediatricians and Committee that I'm proud of. Ladies and gentlemen, based on the assessment of the COVID-19 situation, Indonesia is in a level 3 situation with level 3 community transmission, moderate response capacity, and adequate vaccinations. The increase in cases was in line with the emergence of the new variants of COVID-19 virus, such as the Omicron variant. The total Omicron cases reported up to 11 February, which in children was 573, or 11% of the total Omicron variant cases, with the degree of pediatric cases. 28% was asymptomatic, 54% mild, 17% moderate, and 1% severe and critical. We have already started giving vaccine for children more than 6-year-old to 11-year-old from December 14, 2021. Currently, 66% of the targeted children has received the first dose of vaccine, while 25% of the target has already got the complete doses. For children more than 12 to 18 years old, currently 92% of the targeted children has received the first dose of vaccine, while 73% of the target has already got the complete doses. Face-to-face learning in Indonesia is quite lagging behind other countries, and the losses of opportunity to learn for children are high. And it will have a negative impact in the future for our children. Currently, because Omicron case has resurgence, Ministry of Education, Culture, Research and Technology issued discretions on their letter number 2 or 2022, where areas with level 2 are approved to adjust to 50% of the student capacity. I really appreciate the International Pediatric Associations, which has organized this webinar so that it can facilitate information updates for pediatricians regarding the impact of Omicron to children and solutions how to overcome this. Hopefully, this webinar can have great leverage to reduce child mortality, especially infants and toddlers. Stay healthy, apply health protocols, and protect our children from COVID-19. Thank you.
For your inspiring reminder to us all. The next agenda of our webinar will be moderated by two very special and distinguished guests. It is my great honor today to introduce our moderators for the session. Professor Mortada H.F. El-Shabrawi is an emeritus professor of pediatrics at the Faculty of Medicine, Cairo University, where he was also a full professor of pediatrics from 1997 to 2014. He is a fellow of the American Association for the Study of Liver Disease and a member of several international associations and societies in pediatrics and hepatology, including the International Pediatric Association, European Association for the Study of the Liver, and the International Society of Tropical Pediatrics. With his extensive experience and contribution to child health in Egypt and across the globe, Professor El-Shabrawi has been awarded several awards, including the Cairo University Award of Appreciation in Medical Sciences and the Cairo University Award of Distinction in Medical Sciences in 2018. Good evening, Professor. Thank you, Professor. Next, before we proceed to beginning the session, I will now introduce the second moderator of the session. Professor Muhammad Ashraf Sultan is a director at the Mid-City Hospital in Lahore, Pakistan. Prior to this, he was a professor and chairman of the Department of Pediatrics, King Edward Medical University, Mayo Hospital, Lahore. Professor Sultan is a member of the Royal Colleges of Physicians and a fellow of the Royal College of Pediatrics and Child Health in the United Kingdom. Professor Sultan is a supervisor, second fellowship in Pediatric Infectious Disease, College of Physicians and Surgeons, Pakistan. He was also the program director of the Diploma of Child Health and Doctor of Medicine Pediatrics program at King Edward Medical University, Pakistan. Professor Sultan is a member of the National Technical Advisory Group on Immunization and has served as the focal person of the Integrated Management of Childhood Illnesses Strategy Pre-Service Induction Program. Good evening, Professor.
Good evening.
Good
Hello.
evening.
Good
And
evening.
it's very nice to meet you, Professor. Thank you very much
Thank
for joining.
you.
So to begin our first session, I will now hand over the screen to Professor Sultan. The time and screen is yours, Professor.
Thank you, Anita, for kind words of introduction. It's my profound privilege to invite first speaker of today's webinar, Dr. Angirani Alam. Dr. Angie is an associate professor and consultant in infection and tropical pediatrics. She is head of working group of infection and tropical diseases of Indonesian Pediatric Society. She is also vice chairman of the Outbreak Response, Emerging and Re-emerging Infectious Diseases team at Hassan Sadekin General Hospital. Today, Dr. Engi will talk about how does Omicron affect kids. Dr. Engi, time is yours.
Thank you so much, Prof, for your kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, good afternoon, good evening, ladies and gentlemen. Thank you, dear Prof. Sultan, and also thank you for the IPA. I have an opportunity to present about how does Omicron affect kids. Let me introduce myself. My name is Anggraini Alam from Medical Faculty Universitas Padjadjaran, Hasan Sadikin Hospital, and also member of Indonesian Pediatric Society, and also member of SIG of the IPA. Before I begin, I would like to state that my presentation have no conflict of interest. This is my outline. Within 20 minutes, I will like to give some of this presentation. And this is the graphic of Indonesian Pediatric Society. COVID-19 affects all nations, include our country, my own country, Indonesia. The number of COVID-19 Indonesian children keeps on growing, peak in July to September 2021, where at this moment the main variant was Delta. Due to the government fact action to declare lockdown, the number was declining. But now, when Omicron variant attacked, the number are growing again. This is the paper from Frontiers, from the IPS, Indonesian Pediatrics Society. Until December 2020, there were 175 cases with case fatality rate 0.46, mostly teenager, and followed by 1 to 10 years old. And another Indonesian study showed a high number of fatality rate, as high as 40% in children national referral hospital. So there are the critical patient. And the most common of death was respiratory failure followed by septic shock. The death cases have comorbidities, and one patient could have more than one comorbidities, such like malignancy and also malnutrition. And you know, in our country, tuberculosis is one of the big problems. We are in the third of global case of tuberculosis. Before we continue to discuss the effect of Omicron, it was first discovered in South Africa. At least 50 mutation was found. 30 mutation among them involving spike proteins. This variant has been detected in at least 43 countries, and we can see almost 100% Omicron variant in several countries, including Indonesia. Why it called Omicron? It's because the WHO is using the Greek alphabet to ease non-medic people in recognizing SARS-CoV-2 variants. A fun fact about this, the WHO left out new and C because new would be mixed up with new, and C is a common last name in China. So many questions about Omicron variant. Omicron is found to have high affinity to ACE2 receptor, known as TMPRSS2, and invade cells with endosomal route, rapid replication in nasal cells. While human tissue from bronchus and lung infected by Omicron after 24 hours, Omicron replicated 70 times higher than Delta and original virus in the bronchial tissue. Interestingly, Omicron replicated less efficiently in lung. Omicron is also partially escaping vaccine immunity and infection-induced immunity. This table showed for the sign and symptom. Generally, Omicron have milder symptoms and the hospitalization rate is lower, less than 1%. But the more the virus mutates, the faster it spreads among these three variants. Omicron, of course, spread much faster than others. And other difference is the level of mask that should be used. Well-fitting masks such as N95 or KN95 are recommended to prevent transmission. And sorry, this is the symptoms. You may see that general Omicron milder symptoms. In adults, the data showed much reduction for severe outcome. There were no need mechanical ventilation usage and 91% lower of mortality. Condition in children is not as better as adult, as we can see. Yes, the number was lower when compared to Delta variant, but the statistical difference was not as big as showed in adult patient. So it is not a good news for children. South Africa and West countries continue to report a higher of hospitalization among less than 5 years old group. Kids have a 20 to 25% higher rate of hospitalization with Omicron compared to Delta. Omicron most commonly affect of children less than 5 years old. The main symptoms are fever, cough, vomit, shortness of breath, and diarrhea. A study showed that 20% of more than 100 children up to the age of 13 years old admitted to hospital in US with Omicron infection had convulsion without any history of previous febrile convulsion or epilepsy. And one case, teenager had a convulsion for 1 minute followed by uncharacteristic aggression. Group also one of problem in Omicron. So we see this pediatricians started noticing croup as something that had not observed during the early phase of COVID. And right now in Omicron era, the croup may persist until 2 weeks. In US, the croup percentage in children greatly increased.
Oh, my sweetie.
And the management strategy in Omicron similar with other variants depend on the severity of patient and by WHO or your national guideline. This is the Indonesian guideline of COVID-19, how to manage it. We use remdesivir and dexamethasone in moderate and severe cases, and favipiravir for mild cases. Please allow me to remind you of prudent antimicrobial use. A low proportion of COVID-19 patients have a bacterial infections, less than previous influenza pandemic. This finding do not support the routine use of antibiotics in the management. The use of azithromycin increased dramatically on in-patient COVID-19 setting, causing increased risk of antimicrobial resistance. So my important message, do not use antibiotic for viral infections. Prioritizing the treatment pre and post-exposure prophylaxis of SARS-CoV-2 infection in patients at highest risk for COVID-19 complication and hospitalization. In developed country, outpatient therapies are also extremely limited, prioritizing among severe immunocompromised individuals that cannot receive vaccination. The NIH guideline used Evusheld and sotrovimab in Omicron situation for individuals 12 years old and up. But why we use monoclonal antibodies when we can make by your own antibodies by vaccination? It's so well proven, longer lasting, and less expensive than monoclonal antibodies. Our country is now still giving out vaccination in school-age children, and it's currently doing well. One of the most crucial problems in this pandemic, how children go to school safely, reduce the cases, and prevent death in children. So the government policy must be strengthened. Health protocol must be utilized, increase vaccination coverage, and from the hospital point of view, maybe the intensive care capacity for COVID-19 cases must be upgraded. And we have to upgrade the education to the community, how to know the warning signs of COVID-19. Other important things to lower the death rate, always have routine clinical and death audits. In conclusion, COVID-19 is still a major health problem among countries worldwide, especially with the introduction of Omicron. Various mutations in Omicron lead to its ability, transmission, evasion, and also antibody neutralization. COVID-19, including those by Omicron, may cause convulsion and group in a different common epidemiology age group. And of course, further study is needed to determine impact of Omicron to future. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Angie, for a very, very interesting presentation. I would like to welcome everybody from Cairo here in the Egyptian capital. I'm very glad to be the moderator with Professor Sultan of this very interesting webinar. And I have the honor and pleasure to introduce my very, very old friend, Dr. Yang Puvorwan from Thailand, will give us the next presentation. Dr. Puvarwan needs no introduction because he is a very eminent pediatrician and virologist all over the world and based in Bangkok in Thailand. He is now heading the Center of Excellence of Clinical Virology in the Faculty of Medicine at Chulalongkorn University in Bangkok. Dr. Puvarwan has more than 650 publications in the field of pediatrics, hepatology, virology, and many other areas of viral interest. Without undue elongation, he will give us his top research in the field of virology of COVID-19, SARS-CoV-2 vaccines and their development. Professor Puvarwan.
Thank you very much, Professor Motada, my old friend. First, I would like to thank the IPA and the admin for inviting me for this webinar. I would like to share my screen. Okay, today I would like to share our experience on the Omicron and the vaccine immunogenicity in Thailand. Like you know, the pandemic COVID-19 it look like in the wave, and in each wave the virus change the variant. Like the last one, you see the surging very high prevalence. This caused by Omicron. If you look to the last wave, you see the last wave, this caused by Omicron. However, the mortality of the fatality rate is not increased. It a little bit, it decreased. Like in our country, you see in our country in Thailand, up to the present time, we have the 5 waves of the COVID-19. The first wave occurred in the year 2020 between April and May. You see in this wave, it caused by Wuhan strain. And in the year 2020, in December, we had the second wave. This caused by the grade GH from the neighboring country. And the third wave is caused by the alpha strain. You see, this is the third wave, and the fourth wave caused by the Delta. And the last wave in our country is caused by the Omicron. If you look to the fatality rate, you see our prevalence is surged after New Year. Right now it is in the growing up in number, and the fatality rate is not increased. The fatality rate is allowed 0.2%, or it means that in 1,000 confirmed cases, the death is 2 cases. The Omicron variant we can divide into 3 grades: BA1, BA2, and BA3. You see, this is the BA1, BA2, and BA3. The amino acid change in the spike protein, it looks like this line. But in our country, we follow the change of the SARS-CoV variant. You see, in the last year, this is the alpha strain, and this is the Delta surge. After the Delta surge, you see it occupied 100% for a few months, and after that, this is the Omicron surge over here. And in January, we found that the BA2 is climbing up. Now we are concerning about the BA2. The BA2 may be increased because the BA2 is more widespread than the BA1 of the Omicron variant. COVID vaccination in Thailand, we would like to share our experience. We start vaccine in the late February. We start with the inactivated vaccine, and in the mid of March, we start the viral vector or AstraZeneca from Korea. You see, at the first time we have the limited supply of the vaccine. We use a heterologous immunization because our limited supply. We start with Sinovac, with the first dose and second dose with AstraZeneca. We implement in the July 2020. Why we implement the heterologous immunization? We have the data first, and after that we use our data for the government to implement. You see, for the medical personnel, we use AstraZeneca in July and Pfizer in August. Now we suggest to recommend the third boost. The third boost we start in October. I would like to share the vaccination vaccine in Thailand. First, we study the safety and immunogenicity of the homologous Sinovac and AstraZeneca. You see the side effect of the AstraZeneca when you compare to the inactivated vaccine. The virus vector is a higher side effect than the inactivated vaccine. You see, this is a systemic side effect, the fever, headache, myalgia, or malaise. When you compare to the systemic side effect of the inactivated vaccine, it's very, very low. If you compare the immune response, you see this is a Sinovac or inactivated vaccine compared with the Sinopharm, and this is a virus vector or AstraZeneca, and you compare with this is a convalescent from the natural infection. Due to our limited supply, we try to do the study on the immunogenicity of heterologous and homologous between CoronaVac and AstraZeneca. You see, we found that the side effect is the same, not increased. And if you compare to the heterologous Sinovac first and follow with the AstraZeneca, the immune response is very good, equal to the 2 doses of the AstraZeneca. If you start with the AstraZeneca first and follow with the Sinovac, the immune response is not too good. Why we recommend that the first dose should be inactivated vaccine and boost with the viral vector. You see, with if you look to the binding affinity unit, this is a heterologous, this is a homologous AstraZeneca. Why we use this data and implement in our country? At that time, we do the variant of concern about on the Wuhan, Alpha, Beta, and Delta. We found that heterologous, we can block the Delta strain equal to the homologous AstraZeneca 2 doses. We did the study on heterologous prime boost with the Sinovac and Pfizer and AstraZeneca and Pfizer. You see, if you use a Sinovac and follow the second dose with the Pfizer or BNT, you see the titer you can detect equal to or parallel, comparable with the 2 doses of the Pfizer. If you and it depends on the interval between and prime and boost. If the prime and boost is more than 4 weeks between the CoronaVac and Pfizer, you see the high titer, you can detect it. Yeah, you can detect high titer. Why in the December, the World Health Organization interim recommendation for heterologous COVID vaccine schedule. The World Health Organization use our data. We have done in Thailand to share this data. I would like to show you the third dose booster on the clinical trial on safety and immunogenicity. Due to Thailand, we first immunization with the Sinovac or CoronaVac or inactivated vaccine. Why we suggest to boost after 3 to 6 months We boost with the Sinopharm or inactivated vaccine as a third dose. AstraZeneca and this is a Pfizer and the Moderna. If you look to the side effect of the third dose, you can see that inactivated vaccine is a low side effect, a low adverse event when you compare to the AstraZeneca or the Moderna or the Pfizer. This is a adverse event. If you look to the antibody, you see for the third dose, if you boost with the inactivated vaccine, the titer increased but not too high. It increased around 10 times. If you boost with the AstraZeneca or virus vector or mRNA, the huge immune response is rising nearly 100 times. You see, this is from the baseline over here. This is the AstraZeneca, this is Pfizer, and this is the Moderna. You compare to this is the total antibody, this is the anti-RBD, this is the anti-nucleocapsid. Anti-nucleocapsid you can detect just only in the inactivated vaccine, because nucleocapsid cannot use as an antigen in the virus vector and mRNA. We do the neutralization test between the, you see this is a Delta and Omicron. We found that if you use a third boost, the antibody blocking antibody against the Omicron is quite good. If you use the AstraZeneca or Pfizer or the mRNA, this is a Moderna, compared to the inactivated vaccine or Sinopharm. Why we recommended in our country, we boost the third dose with the AstraZeneca or mRNA, not use inactivated vaccine as the booster dose. This is the FRNT. We use a live virus isolate in our lab, Delta and Omicron. We found that if you use the third dose with the inactivated vaccine, the blocking antibody against the Omicron is very low compared to the blocking antibody, you see, for the virus vector or the mRNA. It's the block Omicron, it's quite good. This is the CMIR. We use a quantiferon. The CMIR can activated by the Astra or mRNA is quite good. You see, this is interferon gamma releasing CD4 and CD8. This is CD4. It means that mRNA and virus vector can activate very well if you compare to the inactivated vaccine. We study the full dose and half dose of the mRNA as a third dose. You see, we use 15 microgram of the Pfizer and 30 microgram of the Pfizer, and 50 microgram of the Moderna and 100 microgram of Moderna. We collect the blood at the 0, day 14, and day 28. We found that the side effect of the 15 and 30 is not different. The objective, we thought that if we reduce the dose, the side effect should be decreased, but our finding showed that the side effect is not, it's not changed, it's the same. If you look to the antibody, we found that between the reduced dose and the standard dose, the comparable antibody can be detected, even in the Pfizer or the Moderna as a booster dose. You see, this is the antibody about the total antibody. This is the antibody about the on the RBD. It comparable, not statistic significant between the reduced dose, half dose, and full dose. We look to the inhibition test. We use a surrogate inhibition test between the Delta and Omicron. You see the Omicron, the blocking antibody, this is a use of live virus. We found that it's lower than the Delta virus, but still detected the Omicron. This is even you use a 15 microgram or 30 microgram or 15. This is for the Moderna. Why? Our study showed that you can reduce the dose of the mRNA as a booster dose. This is the CMIR. The CMIR, the result is the same. If you compare to the 15 microgram and 30 microgram, half dose and full dose of the Pfizer and Moderna, the results are comparable. We studied the COVID-19 infection after the 2 doses of the vaccine, after the 2 doses of vaccination, Sinovac. We found that after infection, the antibody is very, very high when you compare to it, compared to the 3rd boost. You see, this is a very high titer after infection, following the 2 doses of the vaccine. We use the we study after you complete vaccination and get infection, the antibody for against the Omicron compared to the Delta virus, you can detect the FRNT50 up to 200. When you compare to the Delta, the Delta is very high. We study the 3rd dose intradermal. Intradermal, we use the AstraZeneca and the mRNA. The local side effect of the 3rd dose intradermal, this is the local side effect of the AstraZeneca or the virus vector. You see, it led readiness and swelling and painful for a few days. If you follow to the 14 days, it's hyperpigmentitious. Adverse reaction on the ID Pfizer is the same. You see, the reaction of the skin is very high, but the systemic side effect is very low because we use a small amount of mRNA and the virus vector. If you look to the antibody between the intramuscular and intradermal, this is a virus vector, it's comparable. This is a mRNA between the intradermal and intramuscular. This is intramuscular, this is intradermal. It's the same. It's comparable. You can use the intradermal. Okay. We try to do the immune response in 2 doses of Pfizer mRNA vaccine in children and adolescents with cancer. We found that in cancer, the titer is, if the pediatric cancer patient is ongoing treatment, the immune response is lower than the remission or the off treatment. Cancer on the off treatment. You see, this is a virus of concern, and on the Delta, the result is the same. This is a result of the booster dose. Why in the immunocompromised host, even some of them we can boost. Some of them the booster effect is very low. We did the immunogenicity of the mRNA vaccine in liver transplant adolescent. You see, this is a liver transplant adolescent. We found that the titer, when you compare to healthy adult, it's a little bit lower than the healthy adult. This is the titer of the liver transplant in adolescent. This is a binding affinity unit. Okay, now we move to the post-mRNA vaccination and myocarditis and pericarditis. In our hospital, we found we found the patient after the Pfizer immunization in adolescent and caused myocarditis. The definite for the diagnosis of myocarditis, we have to use the MRI to see the MRI diagnosis. This is a pericarditis. We use an echocardiogram. This is the data from the New England Journal. They found that the myocarditis usually occur in the 2nd dose, and the data from the MMWR, you see that this is a female and male. Boy can be cause myocarditis more than the girl, and the younger age. COVID-19 vaccination schedule in Thailand, January 2002. Now, if in young children, we use the Pfizer. This is older. This is children. You see, we use the Pfizer 2 doses. The interval between 8 weeks, or you can use the Sinovac for the first dose and boost with the Pfizer as a second dose 4 weeks apart. If the 12 to 17 year, we can use the Pfizer 2 doses and the or Sinovac and heterologous to Pfizer or Sinovac, and third dose with Pfizer. Okay, that's it for my talk today. Thank you very much.
Thank you, Professor Young, for an excellent overview and update of on COVID vaccines. Now it's my pleasure to invite our last speaker of the webinar, Dr. Thomas Scott Murray. Dr. Thomas is an Associate Medical Director for Infection Prevention at Yale New Haven Children's Hospitals. He is also Director of Pediatric Infectious Diseases Fellowship Program, Department of Pediatrics, Yale School of Medicine. And Dr. Thomas would talk about multi-systemic inflammatory syndrome in children after Omicron infection. Dr. Thomas, time is yours.
Great, thank you everyone. Thank you for the opportunity to speak to you today. And what I'm going to talk to you about is what's known about the MIS-C or the PIMS in children after the Omicron. I have no conflicts of interest to disclose, but I do have to disclose that when I did a literature search in preparation for this talk, the results were no results found. So what I'm really going to do is share with you some of the experience that we've seen at our local children's hospital with MIS-C after the Omicron surge. Our learning objectives are to look at the diagnostic criteria and some of the challenges with this diagnosis, to discuss some of the epidemiology and what we've seen, and look at treatment options and pitfalls. And then at the end, I'll share with you briefly kind of what's happening here in our area in Connecticut. And Connecticut is a small state about 1 hour north of New York City, just to give you a sense of where we're at. And a lot of what I'm going to talk about comes from a new paper from the American College of Rheumatology, which is their third version of clinical guidance for the diagnosis and treatment of MIS-C. So the first challenge for those of us who see these kids and evaluate these children is that there are very broad diagnostic criteria. And essentially you need to have 5 things to consider in making the diagnosis. The first thing you require is fever. The second is evidence of inflammation, which are typically elevated blood markers like C-reactive protein or procalcitonin. And then you need an epidemiological link to COVID-19. And with Omicron, we'll discuss how everybody has that now, it seems, at least in our area. Depending on the organization, and we'll look at this in a minute, you may or may not need hospitalization with involvement of 1 to 2 organ systems. The CDC here requires hospitalization and 2 organ systems, and these can be determined by both laboratory or clinical signs and symptoms from your history and your physical exam. And then the last thing, which is very important, is there cannot be another reason for the clinical syndrome that the patient is showing you. Importantly, when you're thinking about incidence and trying to figure out how often this occurs, different organizations have slightly different criteria in establishing the diagnosis. And a couple of these I've alluded to earlier, but for example, fever can be greater than 1 day for WHO, I believe, but it's at least 3 days, or greater than 1 day for CDC, but at least 3 days for other organizations. WHO, 1 organ system, CDC wants 2, and I won't go through all the details, but not everybody quite agrees on every diagnostic criteria. Everybody does agree on a high C-reactive protein as a measure of inflammation, and PCR positivity is a marker for a COVID link. Serology can also be used, but in an era of vaccination, as we just heard about, you have to be careful how you interpret the serology. So for example, here the children get Pfizer, so we'll have antibody to the spike protein. So we use the nucleocapsid antibody as a measure of exposure to the virus rather than just vaccination. And then finally, you have to exclude other causes, and a couple of organizations just say infection, but the CDC says everything else. And we'll talk about how one might go about doing that. So why is this challenging now? One of the reasons it's challenging now is that in our area, almost all children have an epidemiological link to COVID, whether it's through a family member, through being in school, or they themselves having had COVID. So earlier in the pandemic, if you found a link to COVID when it was mostly adults, you were like, okay, that kind of really pushes you towards MIS-C. Well, now everybody's got that link, so it makes it a little bit more challenging. The other thing that's happening is as risk mitigation strategies are relaxed, such as masking, more children are getting common febrile illnesses. So the more common diseases which can meet criteria are also more common. However, as I'm about to show you, the incidence of MIS-C is likely to increase because of the large number of children with the Omicron variant. And so we've certainly in our experience, we've seen some children be quite ill with MIS-C. So it's a diagnosis that you don't want to miss. So I will be very honest with the group and say that we probably overdiagnose MIS-C. And there are probably a couple of kids who've gotten treated who have other reasons for their syndrome. But we want to make sure we're not missing anybody because we've seen some very sick kids. So here's one clinical approach. It is not the perfect clinical approach, but I think it's one that has been generally successful. These are the recommendations of the American College of Rheumatology, looking at the criteria. They look for unremitting fever, and I'm going to define unremitting as not really being that responsive to antipyretics, such as ibuprofen or acetaminophen. The epidemiologic link, and then they require 2 suggestive clinical features that are shown there. In our situation, many of the children have had significant gastrointestinal symptoms. That seems to be a very common presentation, along with some of the other Kawasaki disease-like things of the rash, the conjunctivitis, the swelling of the hands and feet. And rarely we will see a kid who presents with cardiac dysfunction, and these children need to go immediately to the emergency room by ambulance and be evaluated, not just for MIS-C, but other things, but oftentimes they'll have left ventricular dysfunction as a reason for their shock. If they don't have that, which most of them don't, and they do not meet criteria, one of the things we felt strongly about is very careful follow-up to see how the illness evolves over time, to make sure that the next day they don't suddenly meet these criteria. If they do meet these criteria, and you don't have an immediate alternative diagnosis, then there's a tier 1 screening evaluation. And different places will have kind of a different set of laboratory tests that they do initially. The ACR recommends a complete blood count looking for high neutrophils and low lymphocytes, a complete metabolic panel to look for electrolyte abnormalities, and then inflammatory markers like the erythrocyte sedimentation rate and the C-reactive protein, as well as testing for the COVID link, PCR, or serologies, depending on what's available. And if any of those are positive, we bring those children to the emergency room for a full evaluation. And this will usually involve looking for alternative diagnoses, but will involve an EKG, a D-dimer, to really try to understand the level of disease that the child is presenting with. And I wanted to take a minute and just point out in our experience, some of the alternative diagnoses that we've had in kids where we were almost ready to treat for MIS-C. So these are kids that everybody thought, if you look at the notes in the chart, everybody thought these kids had MIS-C, and then a test came back that suggested something else. So one child had influenza A, and if you think about how influenza, if you remember when we used to have a lot of influenza, how it presents, certainly you can get severe headache, abdominal pain, high fever that's unremitting, and that child had influenza A. We had a child with respiratory symptoms, diarrhea, conjunctivitis, who turned out to have adenovirus as the reason for their illness. Another child came in quite sick with D-dimer elevation, cardiac dysfunction, whose blood culture was positive and had bacteremia and sepsis. And then finally, we've seen a number of kids with severe abdominal pain, diarrhea, high neutrophils, so meeting the criteria, but turn out to have appendicitis. So the rule out of the alternative diagnosis, something that's really important in thinking about MIS-C. First line treatment is IVIG and methylprednisolone, so intravenous immune globulin. And then for children who have refractory disease, and these are children that we would define as either getting worse clinically, ending up in our intensive care unit, or despite aggressive therapy with IVIG and steroids, the inflammatory markers continue to go up and go up significantly. If that happens, then there's intensification treatment. We tend to use high-dose anakinra, which is an interleukin-1 antagonist, the receptor. Others will recommend infliximab, which is a TNF-alpha blocker. So this has been our experience with COVID-19. This is the number of admissions we've had per month. Just to point out, as was previously noted by our excellent speakers, that the surge in children was absolutely real. Before December of 2021, the most kids we had admitted in a single month was 23. We admitted 50 in December and 135 in January. And this number is a little bit out to date in that we're up to, I think, 15 now in February. And then if you look at the numbers per day, you can see that we hit our peak early January after the first of the year. The children were out of school. There was a lot of travel and socialization, which really led to that increase in the number of admissions. And we have also seen, as previously noted by the excellent speakers, the croup and the upper respiratory disease in younger children, which actually, to be honest, made our hospital doctors very happy because they knew how to take care of croup. That's something they're used to seeing with other viruses, so they're very comfortable providing care for children with croup. This is our MIS-C admissions with the Omicron surge. And again, you'll note the highest previous in a month was 8 back in February of 2021. And we had 14 for January, so almost double the high of a previous month. And what's interesting, although it's 14 for the month of January, it's really 14 for the last 2 weeks of January, because it occurred about 3 weeks after that initial surge, which is typically when you begin to see MIS-C. And we did not see really any difference in terms of the clinical presentation or the number of children that required intensive care, usually for severe dehydration or cardiac dysfunction. And that's shown on the right with the red showing the number of children out of the total that required ICU care. And it's somewhere around 20 to 30%, depending on the month. Finally, with respect to distribution, it really is all ages. It's not any particular age. And we do not see the comorbidities in our MIS-C population that we see in our kids getting admitted for acute COVID infection. As previously noted, our experience has been similar in that children typically have underlying problems, multiple medical problems, complex medical problems when they're admitted with acute COVID. But often the MIS-C children, we do not have underlying predisposition and are not good at predicting which child will get MIS-C. The last thing I'll touch on with respect to this is Omicron and COVID-19 vaccination and MIS-C. There's certainly been hope that vaccination would prevent the longer term effects of COVID-19. And I think vaccination will protect against MIS-C in that it protects against the infection itself. So this question is really for kids who get an infection after vaccination. Do they go on to get MIS-C? And again, these numbers are very, very, very small, so you have to take them for what they're worth. But we have seen 5 children who were fully vaccinated, and by that it's 2 doses, which we know isn't fully protective against Omicron, go on to develop MIS-C by the CDC criteria. And one of those children was in the ICU with cardiac dysfunction and was quite sick. You'll also notice we see a number of children that were not vaccinated but eligible, and those are the group that we would really, the vaccine hesitancy previously noted is a huge problem for us. And then we have had a number of children ineligible for vaccine because they were younger than 5 years of age. This is our total hospital experience to date. We're one of 2 children's hospitals in our state. We've had 410 children admitted with a COVID positive test. We test all children for COVID when they get admitted for the infection prevention isolation reasons. 83 of those have required ICU care. As of this morning, I am happy to say we only have 1 child admitted for COVID. Our high in January was 23 on one Saturday a few weeks ago, so that's much, much better. We've had 83 children admitted for ICU. Again, a little more than about a third have required ICU care, and all of those have been discharged safely to home. There was a previous excellent discussion about the myocarditis, and we've had 16 children admitted for post-vaccine myocarditis. What's interesting in our experience is they have all been 12 and older. And so since the introduction of the 5 to 11-year-old, which for us, we use the Pfizer, the lower dose Pfizer, we have had not a single admission for post-vaccine myocarditis. So while our PCR admissions have almost doubled over the last couple of months and our MISC has gone way up, we've been stuck pleasantly in a good way at 16 for several months, something we're very happy about. We're also proud that we have had no COVID or MISC related mortalities so far. We do have a post-COVID comprehensive care program that we ask any child with severe acute COVID or MISC to attend after discharge to monitor how they are doing. So far, the prognosis for the children with MISC has been excellent in that their inflammation has gone down and their cardiac function has recovered. The 2 primary services that follow these children after discharge are rheumatology for inflammation and our cardiologists to look at the heart. Infectious disease is involved, but not as much as those other services. The children with the most severe disease who've been in the ICU are followed very closely. And while, as of right now, we don't seem to see any long-term effects, I'm always hesitant. SARS-CoV-2 is a very surprising virus. And so I think these children require follow-up for months to years to be very clear about whether they're going to be long-term complications. I'll just finish with where we're at in our state. Community levels are dropping significantly. The state of Connecticut was as high as 32% positivity rate. We're down below 4% for the first time in a long time. But what's happening that's interesting is the state government has largely been determining the policy. So our children have been in school with masks since the beginning of the school year, but that is ending next week. The governor has decided that he is going to leave it up to the local schools to decide whether or not to continue to require masking. And there's a very strong group of parents that don't want their children to go to school with masks anymore. So we really expect that mandate to go away and that children starting in March will be attending school with masks optional. And what that means for COVID and other respiratory virus remains to be seen. Vaccination has also been delayed here in the 6-month to 4-year-olds. There was a review scheduled for February that was canceled and has been rescheduled. I believe that's to look at a 3-dose schedule rather than a 2-dose. So we're not likely to see approval for a vaccine for this age group until late spring, early summer. And I have to be honest, those of us who follow this have not been excited about the uptake because in our 5 to 11-year-old group, our uptake is only around 40%, with some pockets in big cities where it's even lower than that, 10%. And surveys of parents of younger children, it seems like it's going to be around 20%. So while we hope it's available and safe and effective, convincing parents that vaccine hesitancy previously mentioned is so important and such a challenge for all of us who try to provide for safe care for children. So in conclusion, the Omicron surge did lead to an MIS-C surge. The clinical characteristics of MIS-C post-Omicron was similar to what we have seen with other variants. It is harder to distinguish from other causes now because everybody's been exposed and other febrile illnesses are starting to show up. Influenza is creeping up here a little bit. We're hoping it doesn't come all the way back when the masks come off, but we're a little bit worried. But we've also found that early recognition and treatment improves outcomes for children with MIS-C. So if we're not sure, we will treat. To be very honest with everyone, because we don't want to miss anybody, because we've seen some kids very early who looked very well, were admitted to the hospital and we delayed treatment and they got quite sick. And I think this all requires careful vigilance as we move forward, because every time I've made a prediction about this virus, I've been wrong. So I try not to do that. Thank you to everyone for the attention. Thank you to the IPA for the invitation. And I would like to acknowledge Lauren Edwards, who has been collecting all of our COVID and MIS-C data since the start of the pandemic. And thank you again.
Thank you very much, Dr. Murray, for a very, very interesting presentation. And now it's time for the Q&A part of the webinar. We have lots of questions. I think we can post some of them on the screen. Can we? We had lots of questions from the registrants before the webinar, and we had some answers for them. Are you going to post them? These are some of the questions who have been addressed to Dr. Young Povrowan, and his answers to these questions. And they covered almost all aspects of what the speakers have said.
Okay, for the first question, the interval between the first and the second dose, for the mRNA, I think if we extend the interval, maybe the second dose of the vaccine may be reduced. But for the inactivated vaccine, I don't think the side effect is change between the first and second dose. And the second question, the third dose vaccination in medical staff and antibody. 6 months after the third dose, we know that after we boost the third dose, the antibody is rising very quickly. We can detect the high, the peak of antibody is allowed second weeks, and after that, the decay of the antibody. We follow our volunteer. We found that the half-life is between 6 to 8 weeks. If we calculate the like a half-life of the antibody, we found that we need the booster dose to increase the high antibody level, because COVID-19 is a short incubation period. And now we do not know the level of the protective level. our recommend we do not know in the future. We need to booster every 6 months. We have to follow the situation. The difference between the third dose, between we study the third dose with the mRNA. We compare between the half dose and the full dose. Now we follow to 28 days. We are going on follow up our volunteer to after the 28 days to see the decay or to of the antibody between the half and full dose. We have no data at the moment. Thank you. With the evidence from adult vaccination that booster with mRNA vaccine will induce higher antibody, should it be implemented for children, considering the adverse event of this vaccine? In our country, if in our kids, if they immunize with inactivated vaccine, we would recommend the third dose boost with the mRNA vaccine. Because we know that the inactivated vaccine for pediatric patients, the titer is not too high. It's not enough to prevent the Omicron. We suggest to boost with the mRNA vaccine as a third dose. You have extensive information on Sinovac, which are useful as many countries. Can you tell the difference? Okay, this we have response.
Thank you very much, Young. Thanks very much. Some more question to Dr. Murray and Angie. Can we share them on the screen? Professor Murray.
Yes, hi, thank you. So will this also apply? We did see MISC also during the Delta wave as well. And one of our challenges, frankly, is we don't test every strain for Delta versus Omicron. So some of what happened in December and January probably represents Delta. By that, with the subset of strains that were tested by the middle of January were all Omicron, but certainly we had a period of overlap as Delta was going down. I think the pathophysiology of degradation increase the risk. There are many people studying why certain kids get MISC and others do not. I have not seen definitive explanation. If other experts on the panel want to weigh in on that, please do. The methylprednisolone is pulsed initially if they're very sick, and then we do transfer it to daily as they go out, and many children will go home on a steroid taper for the MISC if they've been very sick. So unfortunately, we don't know the risk. There's one paper that was published recently describing some risk factors which were somewhat similar to acute COVID. Things like being African American or being obese. I will tell you, in our experience, that has not really been the case. It's really been children of all ages, all different backgrounds, mostly healthy. So I'm not aware yet of a great explanation for the risk factors. Yeah, so the question about anti-nucleocapsid antibody when it's found in the inactivated vaccine, I think it becomes more challenging to interpret the serology. And in those cases, one may also need to look at the epidemiologic exposure. So in our experience, oftentimes when the kids come in 3 weeks later, even if they didn't even know they had COVID, somebody in the family did have COVID, a parent, a sibling. And so oftentimes we can find that direct epidemiological link to a known positive. So that's, I think, the next choice. And frankly, if you meet all the criteria and you don't have an alternative diagnosis, and the incidence of transmission in the area was high within the last month, I think it's reasonable to consider empiric therapy because, again, the consequences of being wrong or missing it, the kids can become quite sick, especially with the cardiac dysfunction.
Yes.
Dr. Morey, before you finish, I have one question. Is there any role of antibiotics in MIS-C children, whether prophylactic, whether for treatment? Because these kids are sick in the ICU, they have high fever, they have all markers of inflammation. And in limited resource countries, especially, we might not be able to do some of the virology studies. So is there any role of antibiotics in this situation?
Yeah, when we admit the kids who are quite sick, we do a blood culture, and often we'll start empiric antibiotics for 24 to 48 hours.
What sort of empiric?
So we'll do something like vancomycin or plus or minus, and usually a third generation cephalosporin, like ceftriaxone or something like that. If they're not, if they're not requiring ICU care, and it's a classic case, we may do a blood culture and either just do ceftriaxone or just monitor closely, depending on the severity of illness. But for the very, very sick kids, we absolutely treat them as though they could have sepsis until we're sure they're not. And we don't withhold the MIS-C therapy either, unless we have a really good reason to. So they get treated for both until we figure it out. Thank you. That's a great point.
Thank you very much. Thank you. Angie, question for you.
About which one is recommended for treating childhood COVID-19 patient, the hazardous material suit or gown only. Of course, the high grade to prevent healthcare worker from COVID-19 is the best. So the hazardous material, hazmat, is the best. But if you have a limited, in limited situation, if you just wear gown only, the important things, please use N95 and also Google, and also face shield is very may help you to prevent you infection from Omicron. And we have to be careful. We do not know whether in our outpatient have no COVID infection. So everywhere, as a healthcare worker, we have to be careful. Please use yes, to protect yourself, protective equipment. Maybe Prof. Thomas, you have your experience there in US. You still wearing.
I agree.
Okay.
I agree with everything that you say. And we also early on had some concerns about people willing to go into rooms, but we use N95 or equivalent with eye protection, goggles or face shield, and then a gown and gloves for all patients with suspected infection. And for patients who are, like you said, we don't always know, we wear at least a 3-ply surgical mask and eye protection for all patient visits, even those that are not coming in with symptoms.
It's very interesting. You wear also for all time to wear Google.
So that is our hospital policy, but I will tell you the number of people that do it is probably about less than 1%. But yes, either face shields for people who wear glasses or the goggles, but we had a conversation yesterday about how we can't get people to do it.
Yes. And which vaccine is recommended for children 6 to 12 years of age and also 12 to 18 years of age? Of course, it depends on your government policy. The best vaccine is the available vaccine in your country and have already authorized.
Good answer. Thank you very much.
You're welcome, Prof.
And there are some general questions for the three speakers.
Time duration to resume routine immunization after COVID-19. There's different policy in every countries. I saw this US CDC. It's okay after you relieve from COVID-19. You may give the routine immunization. In our country, around 1 to 2 weeks after relief infection.
With respect to the myocarditis question, again, in our country, for the 5 to 11-year-olds, we use the 1/3 Pfizer dose, and we have not had any cases of myocarditis in that age group, presumably because it is a lower dose. And unfortunately, I'm not aware of any preventive measure for MIS-C after COVID infection. The best defense is vaccination to prevent the infection in the first place.
Professor Moray, is there any explanation for the myocarditis, the molecular explanation?
My understanding is that they think it is, and I will defer to the other profs on the panel, but my understanding is it's thought to be autoimmune in part, and that is contributing. But again, why it's a predilection for young males, I'm not sure that the answer to that. But there are other vaccines throughout history where there has been some risk. I believe smallpox is an example. I got to be careful because there's an expert, world expert virologist on the panel, so I don't want to overspeak.
So the question is to Dr. Young. What do you think the mechanism of myocarditis after vaccine?
You know, so far we do not know the mechanism. Why in the boy more than girl, but the second dose, I think it may be related to the accumulated doses. I think if you like an interval between the first and second dose be longer, maybe reduce the incidence of the myocarditis. Like you know that when you reduce the dose for the young children, the incidence of myocarditis is lower. You know, when we study the reduced dose and the full dose antibody response, I think in the pediatric or adolescent, maybe we can use the half dose of the mRNA vaccine.
Well, may I ask two brief questions, Murtada? If there is no more question.
Yes, sure.
Yeah,
sure.
My question is addressed to Professor Thompson. Is there any evidence to support that MIS-C patient who doesn't have cardiac involvement, that's one group, and the second one is which presents with coagulopathy only, still would we recommend intravenous immunoglobulin? And I'm asking this question that if there has been any randomized clinical trials to compare these strategies together and in separately, what has been the outcome? Because the age group which affects is this is 5 to 10 years. The IVIG to every patient would be very costly to be afforded by a country like us.
So I have not seen a randomized control trial. I will tell you, in the beginning of the pandemic, for the children who had very mild disease, we only did steroids. And unfortunately, we had some kids who decompensated and got much sicker. And I believe the early recommendations, if you go all the way back to the beginning, did not recommend IVIG for the mild kids. It was just steroids, I think. And once we had that experience, and I think others had a similar experience, we did move to giving IVIG and steroids to all kids, even those with mild symptoms. And those with cardiac involvement or concerns with coagulopathy, we do, as it was mentioned in the chat, give aspirin long-term, and they're followed very closely. So, but no, I agree, it's expensive. And the other thing that can be very expensive, frankly, is trying to work up the alternative diagnoses. Because if you start looking for every virus and doing CAT scans and ultrasounds, it can be very expensive. So it's a challenging diagnostic problem for sure. I agree.
Yeah, my next question would be that I gather from the slide that nearly 50% of the patients presenting with croup during this season was Omicron positive.
Yes.
I was just concerned that there are so many other viruses roaming about during this time of the year.
Yeah.
Has there been any co-infections with other viruses?
Probably. It is the study that showed that almost 50% increased 50% of group caused by COVID-19. In country like Indonesia, it is not easy to check all of the etiology of group. We have no multiplex PCR to check it. So that study help us to differentiate all of a group sign and symptom of group children. It could be the etiology by SARS-CoV-2. So we have to be careful right now. Maybe while a child get a group, the etiology could be COVID-19, SARS-CoV-2. And of course, Prof, it could be a co-infection.
Thank you, Angie. Perhaps that's the time we have for the webinar. Over to the moderator.
Thank you again, the three distinguished speakers, and we have finished our allowed time for the question and answers. But before we finish the webinar, I would like the three distinguished speakers to give very, very short talks about encouraging the medical community to advocate vaccination in children. As you said, Thomas Murray, Dr. Murray, that the vaccine uptake in children 5 to 12 years is very low and is expected to be much lower in 6 months to 4 years. So how can we advocate vaccines in our community, please, in few words?
You wanted to go first.
Okay.
I will say for the most,
our colleagues.
yeah, one of the most important things we can do is to correct the misinformation that is out on a lot of the different social media platforms, and really try to direct parents who are hesitant to accurate places to get their information, and to make sure there's time and visits for pediatricians to have those discussions and make time for those important discussions.
Thanks, Tom. Young, Angie?
Yes, for me, I think that we have to inform the doctor first, you know, many doctors against the vaccine.
Yes, great, Young. Angie?
Yes, we have to sit together with stakeholders, especially in limited resource country, the government policy to strengthen to reach the coverage, high coverage of COVID-19 vaccination is very important.
Thanks, Angie. Thanks, Young. Thanks, Tom, for very, very interesting presentations and very fruitful discussion. And back to the admin office to conclude the webinar.
On behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers, moderators, and participants for making the international webinar on what we know about Omicron in children a great success. We hope that this webinar has equipped you to become agents of change, champions regarding Omicron and COVID-19 in children in your respective countries and communities. Furthermore, the International Pediatric Association conducts routine webinars with a wide range of topics concerning child health. To keep yourself up to date, we urge you to follow IPA on our social media platforms as detailed on the slide. We have two upcoming events. First, IPA will be having the IPA Congress next year in 2023. Register before the 28th of February 2022 to receive the early bird discount. For more details, log on to www.ipa2023congress.org. Next, IPA will also be having the next webinar very soon with the title of Pitfalls in Pediatric Surgery, What the Pediatrician Needs to Know, held by the IPA Education Advocacy SC Subcommittee on 24 February 2022. This webinar is exclusively for pediatricians, doctors, and healthcare professionals. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at our next webinar.